arthritic conditions, the capsules of the joints will tend to thicken or become sensitive, and they'll need some release work. When working the joints of the toes in specific, you have to be careful not to use the toe as a lever. So you'll be using more force on the tissue of the capsule than you are pushing the toe. If you do it in reverse and push the toe harder than you go on the capsule, it will be quite sensitive. In working this joint, for example, we'll have to work the capsule all the way around. We'll start by working this joint, and I'm going to take a distal tension along the capsule tissue. I'll start on the proximal side of the joint, compress just a little bit with a soft contact. I'll start with the toe in a position that shortens the capsule on that side, so an extension and a little bit of abduction. Compress and then move into tension, and then move the joint away from my contact point. So in this case it will be mostly flexion but a little bit of adduction. A little bit of pressure on the toe itself, but most of the pressure is going to be along the capsule. And then I'll work with fingers or thumb around the joint so that I get all the surfaces of the capsule. Working on the medial side, you have to be very careful about moving the toe into adduction. It's not going to go very far that way, so I'm going to primarily depend on the flexion. And then up and out with my contact in this position. You will need to reverse your contact tension as well. I'm going to start on the distal side of the joint. Same type of contact. Broad and soft, compress first, and then take tension across the joint, and then move the toe in a direction opposite of where my contact is. Again, working all around the joint. There's a lot of passes to make because I've got to get 360 degrees around this one and each of those interphalangeal joints. The same principle can be applied to any joint, but primarily in this case we're working on the interphalangeal and the joint on the proximal side of that first phalanx. The plantar aponeurosis is very tough tissue. You have to be very careful in how you apply your tension and how much tension you apply. You're going to have to go fairly hard, but if you go just slightly too hard on one pass, then the tissue will instantly become sensitive and you're pretty much done for the treatment for that day. It's on the center of the foot here and then spreads out, and the slips go into the toes. So I can work all the way from the toes down into the arch of the foot and to the calcaneus. For demonstration, I'll work the central portion, which most people, when they feel a problem, it will be in this central portion. And I'll start by flexing the arch of the foot down and the toes down, take my tension towards the calcaneus, compress first, feel the aponeurosis, then take my tension, and then extend or dorsiflex and take the toes up. As the tension increases, it'll reach a point where it exponentially increases. That's when you have to be careful. If you just force it towards the calcaneus, it'll pull too hard and then it'll make it sensitive. So a little bit of art to applying the tension to this. And then I'll apply that tension in all of this area step by step. When my thumb is in on this, once I get the tension increasing, I'm not so much sliding my thumb towards the calcaneus as rolling my thumb this way to increase the tension. If I roll my thumb in like this, it'll decrease that tendency to make the tissue sensitive. Once I've done that in this entire area from here to here, then I'll reverse my contact. And I'll use a thumb backed up by another thumb. I'll compress on the attachment site on the distal side or the foot side of the calcaneus here. And I'm going to compress in until I reach the tissue. And then again, I'm going to roll my thumb this way to apply the tension. So plantar flex, toes down, compress in, roll my thumb in to grab the tension, and then bring the foot and the toes up. And then if I need to help, I can put a shoulder on there and help the dorsiflexion or the toe extension, but usually the patient will be able to do it sufficiently. And then I'm going to roll with tension this way away from the calcaneus. Again, it's not sliding up, it's compressing in and then rolling up to get the tension. You can be very firm on this contact and the tension. This one does not tend to get sensitive, and because the tissue is so tough, you may have to get very close to the calcaneus and apply quite a bit of tension force as the patient does the motion. The flexor digitorum brevis is a relatively short muscle. We'll have to be careful to get full range of motion of the toes. We'll start by flexing the toes. Dorsiflexion and plantar flexion won't matter that much. It'll just tend to relax the other tissues around it. So we're gonna start in plantar flexion and keep the ankle in relative plantar flexion. Flex the toes, go straight in on the muscle, roll my thumb and take a tension towards the calcaneus, and then extend the toes, and I'll assist by pulling the toes back as I hold the tension towards the calcaneus. I may have to do a couple passes to get the medial and lateral portions of that set of muscles. Once I'm done with that, I can reverse my tension by having the patient flex the toes, take a double thumb contact, roll in just on this side of the calcaneus, then take my tension towards the toes, hold that, and have the patient extend the toes all the way. If they can extend the toes like this without dorsiflexion, that's great. If they dorsiflex a little, it won't really interfere with the tension on the muscle that much. Okay, extend the toes. The abductor digiti minimi is a very small muscle, but it's surprisingly important and effective in stabilizing the foot in gait, either walking or running. So when there's a problem there, we'll have to address this muscle. We'll start by flexing the small toe and abducting, and then taking attention along the fifth metatarsal, being careful not to compress the muscle against the edge of the metatarsal. So compress first to get to the muscle, and then roll my thumb, and then take tension towards the calcaneus, and then bring the toe into extension first, and then adduction across the rest of the toes while I maintain a tension towards the calcaneus. Several passes to get the full length of the muscle. At the proximal end, you may want to try to reverse the tension, going distal and then extending the toe and adducting across. To work the flexor digiti minimi, I'm going to place my contact on the distal portion of the muscle, and I'm just going to be medial to the abductor digiti minimi. So I'll roll my thumb onto this side and then get in the little gap on the medial side of this metatarsal, compress in till I reach the muscle, push the toe in flexion and adduction, and then take my tension proximal towards the calcaneus. Then I'll move the toe into extension and abduction a little bit. Have to be careful not to push too hard on that while I maintain the tension towards the calcaneus. I have to be careful to use more tension with my contact hand than I'm adding pressure onto the toe. Most of the motion is going to take place with extension of the toe rather than abduction. Working the quadratus plantae involves a difficult motion for the patient, so it's probably good to explain what you're going to do first. We'll start with the ankle dorsiflexed and the toes flexed. Well, that will do, it'll shorten the quadratus plantae, but it'll stretch on the flexor digitorum longus, which will tend to additionally shorten the quadratus plantae. And then what I'm going to do is take my contact proximal, but I'll explain to the patient that we'll plantar flex, which takes the tension off of the quadratus plantae from the flexor digitorum tendons, and then we'll extend the toes to further stretch the muscle. So it's a little bit backwards motion from perspective of the patient. Start in dorsiflexion, flexion of the toes, go deep enough to get to the quadratus plantae, and I'll be on the lateral side of the fibrous attachments against the tendons. Take my tension slightly laterally, but mostly towards the calcaneus, and then plantar flex and extend the toes. The abductor hallucis is a surprisingly strong muscle. It's easy to palpate on this medial side of the first metatarsal. We'll start by flexing the toe and abducting, and then taking attention on the muscle from distal to proximal. I'll compress in till I reach the muscle, and I have to be a little careful again not to compress the muscle against the edge of the first metatarsal. So I have to shape my thumb to match the contours and make it soft and pliable, compress enough to get to the muscle, and then take my tension without having a rigid thumb compressed against the metatarsal. Flex and abduct the toe, compress in, roll my thumb, bring my tension towards the calcaneus, and then extend the first toe and adduct across the rest of the toes. The adductor hallucis is also a strong set of muscles. It comes in two parts. The longitudinal head will come down from the first met across the arch of the foot to this area here, and the transverse head will be underneath the flexor tendons across here. The longitudinal head is the easiest to work, and we'll start by putting the first toe in flexion and adduction, and then compress to get the longitudinal head real close to the first metatarsal, but then on an angle into the arch of the foot. Compress and take my tension towards the calcaneus and the lateral part of the foot, hold that tension, and then move the toe mostly into extension and a little bit of abduction. Once I've finished my passes on that longitudinal head, I'll go to the transverse head. The transverse head, once it's shortened, it tends to hold the toe in adduction, causing bunion problems and shoe hitting problems on this side of the foot. So it's very important to work that. We'll start with the same toe position in flexion and adduction, and I'm going to use several fingers to contact the bulk of the muscle, go in between the flexor tendons, fairly deep, trying to go in between those tendons till I reach the muscle, hold a firm contact, then take my tension laterally along the fibers of the muscle. I'll hold that tension, then move the toe into extension and abduction while I increase the tension this way across the foot. If you don't go deep enough to grab the muscle, you'll find that your contact will start to slip, and you'll be going over the flexor tendons, and you won't be able to treat the muscle at all. So you do have to get in deep enough to get to that transverse head of the adductor. To work the flexor hallucis brevis, we'll have to go on one side or the other of the longest tendon. I can extend the toe and see and feel the longest tendon right here. So I'm going to pick a spot on either side of that, flex the toe, compress to get to the muscle, then take my tension proximal, and then extend the toe. and I'll have to change the position of my contact thumb to avoid going too hard on the longest tendon. Once I've worked that side, I'll switch to the other side and do the same motions to get the full width of that muscle. I can use a thumb contact from this side, or if it's easier for you, you can use a 4-finger contact using the other hand. Again, work both sides of that longest tendon to get to the brevis muscle. Working the lumbricals, we'll have to be ready to compress deep enough to get back past the flexor tendons and the quadratus plantae and the aponeurosis. So we'll find a way in between those slips, and we'll work each of these gaps in between the toes. So I'll start in this gap in between the first and second toe. I'll use fingers, go fairly deep, flex the toe, then go deep and take my proximal tension, and on each of these 3 middle toes I'll take the toe into extension and then abduction, or towards the small toe side of the foot. And I'll do each of these 3 toes, so I'll be just on this big toe side of the metatarsal, and I'll take the toe into extension and abduction on each of those 3. When I get to the gap in between the 4th and the 5th toe, I'll move the toe into extension and then take it across towards the big toe. To work the plantar interossei, we're going to use each of these 3 smaller toes, move them into flexion and adduction, move them into extension and abduction. But we'll do one of them at a time. So I'll go on the gap just medial to this middle toe, compress into the interosseous muscle after I've flexed the toe and adducted it, then hold my tension towards the calcaneus and extend the toe and abduct as I hold the proximal tension. Then I'll do that for each of the 3 smaller toes. Several passes in between each. I'm going to treat the dorsal interossei for these 3 middle toes with the same motion. I'm going to start with them extended and abducted, and then move each one of them individually into flexion and adduction. So for this second toe, I'll put my fingers on the lateral side of that metatarsal. I'll move the toe into extension and abduction, compress to get to the muscle, and then take a proximal tension, and then move that one toe into flexion and adduction as I maintain that tension. I'll do subsequent passes in the same manner, and then I'll switch to the next metatarsal, be on the lateral side of the middle toe metatarsal, extension and abduction to flexion and adduction, and then the 4th toe in the same manner. Once I've done the 3 of those, I'm going to switch to the medial side of this second toe. I'm going to switch hands so that I can hold a pressure against the second metatarsal. I'm going to move the toe into extension and adduction, take my contact, proximal tension, and then move the toe into flexion and abduction as I maintain the tension. As the foot and the ankle dorsiflex and plantarflex, the talus has to move in the mortise like this. If you notice on the back side, the talus actually has to descend away from the fibula and the tibia. If the posterior talofibular ligament is a little bit shortened, it'll interfere with that motion, causing problems on the front side of the joint. So the easiest way to work that is to use a 2-finger contact with my opposite hand coming underneath the ankle and wrapping around, and I'll be on the back side of the fibula. Use a slight inferior tension until I get to the tendon or the ligament, and then I'm going to take a tension on an angle towards the talus not perfectly inferior, but a little bit posterior as well. Then I'm going to back it up with this hand, so I have a lot of strength using this hand, and then I'll use both hands like this to squeeze and then turn my fingers down like this, so I can have a very soft contact, although it's quite a bit of force. Contact the ligament, tension posterior and inferior, and then I'm going to use my shoulder to dorsiflex the ankle while I maintain tension this way from the fibula to the talus. Once I get in this position at full dorsiflexion, I may want to even move the talus and the foot medially so that it turns the talus just a little bit, one way or the other, whichever way has the most resistance, so that then I get a free motion of the talus in the ankle mortise. Soft contact, firm pressure. In working the calcaneofibular ligament, which is from the fibula to the calcaneus right here, almost straight up and down, but it does go a little bit posterior as it approaches to the calcaneus. I can use any thumb or finger, but you'll find that if you wrap the other hand around like this and use two fingers with a tension towards the calcaneus, you'll have the best combination of physical authority but soft contact. I can back it up with this hand, start with the ankle like this, everted and dorsiflexed, plantar flexed, and then move the ankle into inversion and dorsiflexion while I maintain a tension this way, posterior and inferior, on that ligament. You may need to use the other hand just to guide the ankle so that the proper motion is obtained. Anterior talofibular ligament is often affected by an inversion sprain. The ligament runs from the front side of the fibula to the talus right in here. So we'll shorten that by moving the ankle into dorsiflexion and eversion, taking my contact on the talus and then rolling my thumb in towards the fibula, then moving the foot into plantar flexion and inversion to tension the ligament as we maintain tension towards the fibula. We can do a reverse tension from the fibula to the talus with the same motions of the foot. The posterior tibiotalar ligament, strong ligament on the medial side. In order to get a good contact with this, we'll use the tibia towards the talus, inferior and a little posterior. I can wrap the other hand around and add a little compression and then use that to increase the tension on the ligament while we take the ankle from plantar flexion to dorsiflexion, and then if we need to, we'll test with moving the foot medial and laterally to get full motion of the talus once it's dorsiflected. So we'll start with plantar flexion. Just relax just a little bit right there. Compress onto the ligament, take a distal and posterior tension, and then use my shoulder to move the ankle into dorsiflexion, and then check deviation to each side to see which one tightens up that ligament the most. Several passes with that motion. The anterior tibiotalar ligament will be worked by first placing the ankle in dorsiflexion and then deviation to the medial side so that we shorten the ligament from the tibia to the talus here as much as we can. Once that's done, I'll take my tension by placing my thumb over the talus and then rolling it towards the tibia to tension on the ligament, then move the foot into plantar flexion and deviate to the lateral side to stretch the ligament as much as possible. The ligament is in the depression here anterior to the tibia, so we're going to have to roll our thumb this way to get the tension. If I just try to slide my thumb this way, I'll be right up against the tibia right away, and I won't be able to treat the length of that ligament. The tibiocalcaneal ligament runs almost vertical from the tibia to the calcaneus, so I'll have to rely on this inversion and eversion motion in order to shorten the ligament and then lengthen the ligament. I can use multi-finger contact, take tension distal off the tibia, use the other hand to accomplish the ankle motion with a tension inferior, or I can use a thumb and accomplish the same motions. Easiest to use a distal to proximal tension with the thumb and a proximal to distal tension with the fingers. The relative positions of the tibio-navicular and the tibial-talar ligament are close, so we use the same ankle motion. But what I'm going to do is move my contact just a little bit medial from the tibio-talar ligament, a little bit towards the inside of the foot to get to the tibio-navicular ligament. Then I'll shorten the ligament by going with the ankle into dorsiflexion and inversion, take my contact near the navicular, compress, and then roll my thumb up towards the tibia, move the ankle into plantar flexion and eversion while I maintain a very firm tension towards the tibia. The flexor retinaculum is a thin band over the tarsal tunnel. That may become shortened and cause a problem in that tissue itself. What we'll have to do is invert to shorten that. Because it runs slightly posterior this way, I'll also plantar flex just a little bit. Now I'll take a multi-finger contact and take a distal and posterior tension right along the fibers of the retinaculum and move the ankle into eversion and dorsiflexion. As I do this, I have to be careful not to point the fingers and compress, because I'll have the veins, artery, tendons in the contents of the tarsal tunnel, and it'll be too sensitive. I won't be able to get any tension on the retinaculum. So broad contact, let these digits bend back, shorten it, then lengthen it, dorsiflexion, eversion, maintain a tension this way towards the calcaneus without too much compression into the contents of the tarsal tunnel. The extensor retinaculum is an involved system of bands. The first one starts across the ankle just above both malleoli, comes across to the medial malleolus, and then a section goes under the inferior malleolus of the side of the medial malleolus to just distal to the lateral malleolus, and then across to this first metatarsal phalangeal joint, and then a small band goes over the extensor hallucis and digitorum. I said that wrong. I'll just do. And then a small band comes across the extensor hallucis brevis in this section here. I can work any of these sections, and what I want to do is find my position on that band. If you have trouble finding it, have the patient strongly dorsiflex, and then you should be able to see where it holds the tendons down. So the superior band is right here. I'm going to take a tension into the band and then roll my thumb to hold a proximal tension, and then move the foot into plantar flexion and the toes down so that all the tendons and muscles slide underneath it while I hold the band superior. And then I'll do that for each part of these bands in order, and then the last part across the extensor hallucis. Once in a while you'll find that the superior and inferior perineal retinaculum becomes a little bound up, and it'll start interfering with the slide of the peronei underneath there. I'll take a contact. I'll first put the ankle into plantar flexion and eversion to shorten up the tendon and move the tendon proximal up towards the peronei. And then my first retinaculum will be from the fibula to the calcaneus right here. So I'll take a two-finger contact, compress, and then take my tension mostly inferior, just slightly posterior as well, and then move the foot into dorsiflexion and inversion as far as I can while I hold the retinaculum inferior and posterior as the tendons slide underneath that. The second part will be a little bit more anterior to that on the calcaneus, and I'll move the ankle back and forth until I can feel, actually even see, where these peroneal tendons come right through here, and I'll put my contact, this one I'm going to take a tension superior, start with the same ankle position, and then move into dorsiflexion and eversion, holding that tension superior and a little bit posterior as the tendons slide underneath distal. The extensor hallucis brevis and the extensor digitorum brevis, I'll start with the toes extended, all of them, and the plantar flexion and extension won't really matter in this situation. I'm just going to put the ankle in a relatively neutral position so that the longest extensors are not real tight. So I'll just get them to relax a little bit right in here. Have the patient not hold the ankle up, so those will relax in there. Take my tension by compressing on the extensor digitorum brevis first, rolling my thumb towards the sinus tarsi, and then taking all four of the smaller toes and flexing them as I maintain the tension into the sinus tarsi. And then I'll switch to the extensor hallucis brevis by moving my contact over towards the first ray, rolling my thumb in towards the sinus tarsi, and then moving the big toe into full flexion. Tibialis anterior is the larger, more anterior and superficial of the anterior compartment muscles in the lower leg. If you have the patient dorsiflex hard, you can see the tendon of the tibialis anterior here and then see the contraction of the muscle there, although it's easily palpated and easily found. The best way to work this is to use this opposite hand, maybe even put your fingers underneath the lower leg. Wrap the thumb around so that it's not on the edge of the tibia here, so that my contact is just off of that. Whichever hand you want to use will work fine. But I'll pick one and then start with the ankle dorsiflexed. If you help the patient a little with this, then they won't have to contract the muscle as hard and it'll be easier to get in. So I'm just going to assist a little bit and push the ankle into dorsiflexion. I'm going to use both hands off of the tibia, compress, roll my thumbs up into the tibialis anterior, and then have the patient plantar flex as far as you can and invert as far as you can, just a little bit right in there. That's perfect. Sense your contraction by just holding the ankle up a little bit. Then go into the muscle with a little compression, roll the thumbs up and take my tension by pulling my fingers down and the thumbs up like this. Hold that tension and then have the patient plantar flex and evert as far as they can, and then subsequent passes all the way up the length of the muscle. You may have to treat the proximal end by reversing the tension. The motions for the patient are the same, and then we'll use a distal tension for this short distance right at the proximal attachment. Ankle up, tension inferior, and then plantar flex and evert. The extensor hallucis longus will mostly lie underneath the tibialis anterior. So I can work that muscle in the muscular portion anywhere from about this area all the way up to here. I'll pick my spot or check every part of the muscle. Move the ankle into dorsiflexion and the big toe into extension, and then take my contact in on the muscle and then roll it proximal to take my tension and then back it up, and then have the patient plantar flex and flex the big toe down as far as they can. If that's a little difficult or there's a problem with the toes cramping, you can have them relax here, and I'll just press down on the ankle and the toe a little bit, being careful not to put too much pressure on the joints of the big toe. Several passes to cover the distance, and then to finish off, I may need to get the proximal portion with a reverse contact, ankle up, toe up, take my tension in on the muscle, inferior tension, and then ankle down, toe down, and stretch. Hold it for a few seconds to finish off. The extensor digitorum longus can easily be found in the muscular portions on the leg. It'll be just lateral and some of it deep to the tibialis anterior, so it'll be right in this area here. So I'll either treat the whole area or pick my spot. For demonstration, I'm just going to pick a spot in the center mostly. I'll have the patient dorsiflex and move the four toes into extension, maybe even evert just a little bit. Hold that position, and I'll take my contact deep to the muscle and then roll it up with a proximal tension. Hold that. Have the patient move into plantar flexion, inversion, and flex the toes. Flex the toes all the way. And then hold that for a few seconds at the end, and then I'll repeat those motions through the length of the muscle. To get the proximal end, I'll do the same patient motion, but I'll take my contact deep into near the attachment of the muscle, roll in with a distal tension, then have the patient go into plantar flexion, flex the toes, and invert just a little bit. As far as you can go. The flexor digitorum longus is probably the most frequently involved in what's commonly called a shin splint situation, where the fibers which attach into the posterior tibia themselves become scarred up and less resilient. The sideline position is the easiest position to work this in, and for this leg I'm going to use this left hand. I may put my fingers underneath, but for this I'm going to put them right on the side and then wrap my thumb around, and I'm going to be compressing in behind the tibia and then squeezing with my hand to go up against the tibia and then on a proximal tension. So I'll have the patient in this position. This way I can just use my leg and then go from plantar flex to dorsiflex this way. Now I have the knee in this position just so that you can see, but the opposite leg will normally be right over here so the patient doesn't have to balance on the table much. We'll move this out of the way just so that you can see. We'll start with the ankle relaxed, but more in dorsal or plantar flexion than anything else. I'll pick my spot along the posterior tibia, go in from the medial side, compress into the bulk of the muscle, and then move in towards the tibia, use both hands. So my right hand here is supplying all the force. My left thumb is very relaxed, and I'm just changing the shape of my thumb to match the contour of the tissues. So I'll go in close to the tibia, but I'm not rigid with my thumb, which will cause it to be too sensitive. Compress in, take a proximal tension, and then move the foot into dorsiflexion while I maintain a proximal tension, and I'll check the full length of that muscle along the tibia. This is the best way to treat the bulk of the muscle. It can be also treated in the prone position. So I'm going to move one leg out of the way just a little bit again so you can see. But what I'll do is I'll start on the medial side here, kind of pull the tissue lateral so I can get in behind the tibia. Move down this way just a little bit. That's good. And then I'll use, again, my other hand for the force, move laterally to get in behind the tibia, and then proximal along the muscle, and then move the foot into dorsiflexion. I can lean into it easier this way. It's just the angle of approach and the hand position isn't as good for getting a nice soft contact against that muscle. If you need more relaxation of the gastroc, what you can do is have the patient stand up. Yeah, put your foot right there, your right foot right there. And then the left foot will be on the table right here. And you'll have them forward enough so that you can approach from right here. And this flexed position of the knee will relax the gastroc, and if you have to go through the gastroc, then it'll be easier to do so. You also have a nice mechanical advantage in this position where you can just lean against the table, and then I'll use my fingers and my hands to twist into tension along the muscle. Once I have the tension set, and then I'll push the ankle into dorsiflexion with the help of the patient's active motion. If you work the tibialis posterior with the patient in the kneeling position, you'll be able to take most of the tension off the gastrocnemius and make it easier to get through that to the tibialis posterior. So it'll be right in the center of the calf. You do have to be careful where the vein is. You don't want to compress directly on the vein, especially in an elderly person. So I would go one side or the other. If you have to move the vein out of the way, do that. But I'll go in this position and start with the patient in a relaxed plantar flexion, not too tight. Go in through the gastrocnemius, use my opposite hand for all the force, and use my fingers and wrist to twist to generate my tension like this. Once I've gotten in deep enough to grab the muscle through the gastroc, then I'll apply my tension, then have the patient dorsiflex as far as you can, and I'll assist that at the end in order to generate the most tension. And lie down prone. I can generate the most force with the patient in the prone position, just leaning straight on it. Have the patient plantar flex, generate my tension in the same manner as we did before, and then patient dorsiflex and assist that at the end. The only difficulty with this is you'll have the gastrocnemius just a little bit tighter, but if it's not a problem, then you can go through it in this manner. When you have a problem with the flexor hallucis longus, it will really disrupt the stability, pronation, supination, and dorsiflexion, extension of the toe. It's very important to make sure that that muscle is free and strong to do what it needs to do. There are two main spots that will be problems. One is where the tendon or muscle, it's actually muscular as it comes around the ankle through here, but where it crosses underneath the Achilles tendon in this area, sometimes it gets hung up underneath the Achilles tendon. That's a main spot. And then the bulk of the muscle up laterally towards the head of the fibula will be the second major spot. So to get this lower spot, we'll go on the side of the Achilles tendon onto the flexor hallucis longus muscle, go in deep on the muscle, take a proximal tension up against the tendon, maintain the tension, and then have the patient dorsiflex and extend the big toe. And if I can, what I'm going to do is help dorsiflexion, and if the table's high enough, I can reach under with my knee and make sure that the toe goes all the way up. If you need, you can use another hand and make sure the toe goes all the way up, but usually the patient has enough authority with that to move the ankle and the toe up into extension sufficiently. It's probably more important to maintain a real good tension with both hands in this manner. Once it gets underneath the Achilles tendon, I need to treat the bulk of it with the opposite hand usually, so I'll wrap my thumb around, go in deep through the gastroc, through the soleus, onto the flexor hallucis longus, take a proximal tension, move the ankle into dorsiflexion and the toe into extension, maintaining a proximal tension. I may even need to reverse that. We'll demonstrate on this side. Same patient motions here, but I'll start near the head of the fibula and take a distal tension along the flexor hallucis longus, and then the patient will move into dorsiflexion and extension of the big toe. In the kneeling position, this will take the tension off of the gastrocnemius, not so much the soleus, but the gastroc will relax. I'll start with the same position, plantar flexion, flexion of the big toe, come in right alongside of the Achilles, take a proximal depth and then tension with both hands, moving the Achilles tendon over a little bit, and then dorsiflex and extend the toe. And then I'll repeat those motions all the way up the flexor hallucis longus, going laterally as I go up to the head of the fibula. Then just as we did before, at the end we can reverse the tension at the top end of the muscle. A shortening of the transverse intermuscular septum can be involved in compartment syndromes. Because it's not actually the muscle and it won't be moving proximal and distal, it's difficult to generate a lot of tension on it. But what we want to do is make sure that we go deep enough to get a little contact with the septum and then use enough force to draw it proximal. And then as the deep compartment muscles move inferior, you can get a little relative motion between the two and then hopefully soften up the septum itself. We'll start by plantar flexing and the toes flexed as well. Go deep enough to get to the septum in between the two compartments, and then grab that and then tension it superiorly, and then dorsiflex and then toes extended, assisted if you can, but a good soft but firm tension onto the septum to try to stretch it superior as you go. The same thing can be done with the standing or kneeling position. This will relax the gastroc and make it a little easier to get in. But same motions, deep enough to get to the septum, roll it up, one side or the other of the artery and vein so that you're not on those, and then dorsiflex, assist if you can with the dorsiflexion and extension of the toes. The peroneus longus and brevis are almost always injured in an inversion sprain. All too often, though, they're not adequately treated, so that the person ends up with a weak ankle. When you sprain an ankle, you have to defeat these two muscles first, and then you'll get to the ligament. And much care is taken for the ligaments, but we also need to treat the muscles too so that the ankle becomes strong and you're not left with a permanently weak ankle that rolls all the time. So the muscular portion will be above the ankle. The peroneus longus and brevis are in this area from here to here. So I'm going to use my opposite hand and wrap around on to the side of the lower leg. Have the patient go into plantar flexion and eversion here. And then I'm going to take a contact into the muscle and then proximal and use my fingers to twist like this, but I'm going to use both hands to do that. Into the muscle, then proximal to generate my tension, and then the patient is going to dorsiflex and go into inversion. The way we usually explain it to the patient is start down and out and go up and in. And just do this motion for them a couple times till they get the hang of it. And then I'll use that motion and treat the entire length of both of those muscles. And we'll do that, both of the muscles, all the way to the proximal end. Once I get to the proximal end, I'll probably need to reverse my contact and take a distal tension. Same patient motion, distal tension, down and out to up and in. Maintain my tension at the end for the proximal end of those two muscles. Peroneus tertius is a relatively short muscle, but surprisingly strong for its size. We'll shorten it by moving the ankle into dorsiflexion and eversion. Take my contact in this area in the middle of the muscle, compress to get into the muscle, and then roll my thumb up and in to generate tension. My hand can be either like this or use two thumbs like this, but when I use two thumbs I want to make sure that this stays flexible and soft while this one supplies pressure behind the thumb, not necessarily just on it for compression. Soft thumb, roll in, generate my tension, and then the foot will go into plantar flexion and inversion to stretch peroneus tertius. Achilles tendon is quite difficult to work when it's inflamed. It's probably best to do what you can to reduce the inflammation before you work it. But in situations like that, it's going to be tender. It's best to start by working either side of the tendon and the tissue anterior to the tendon itself so that you release all the tissue around it to take all that friction pressure off the tendon. So we'll start by placing a thumb, patient in dorsiflexion or plantar flexion, and I'll go in this little gap with my thumb right next to the tendon, push against the tendon anterior to it and then proximal, and then have the patient dorsiflex, assist if I need to. And then I'll do that on both sides. I'll do that on the medial side of the tendon with the same motion. Go ahead. And then probably most importantly, I'm going to work the gastrocnemius and the soleus muscles and get them completely released and let go to take the tendon off, or the tension off of the tendon. Now, sometimes the tissue inside the tendon will be disrupted, or you'll have some scarring inside there. And the only way to feel that is to go straight in on the tendon and wiggle around, and you'll feel a hard area in the tendon or a thickened area in the tendon. In order to get that, I want to avoid this motion where I use a light contact and then start with my tension, because you just stretch all this superficial tissue on the surface, and you'll make it swell and cause inflammation and make it extremely sensitive if you do that. So unlike some of the protocols, what we'll have to do is we'll really firmly have to go straight in on the tendon until you get deep into the tissue where the problem is. And then rather than move my thumb like this to generate tension, all I'm going to do is roll my thumb in to generate the tension. If I slide my thumb at all, I'll irritate the heck out of the tissue. So slightly plantar flexed, just slightly, so that you don't contract too hard. And then straight in on the tendon, wherever I find the thickest, hardest area, straight in, roll the thumb in to generate tension, and then dorsiflex, and then I'll add a little help while I maintain a very strong depth and tension with my thumbs. Notice that my thumbs don't slide up at all. They're just rolling and twisting in like that to get to the deepest part of the Achilles tendon tissue. The gastrocnemius is the easiest of the calf muscles to get to and treat, but we'll do it in two parts. We'll start with the patient prone, because this is the easiest position for me to just apply some leverage and use my body weight, so I don't need as much hand strength, so I generate lots of tension without too much effort on my part. That way I can be steady. So working the lateral part of the gastroc, I'll use this hand and cross my thumb over. Working the medial part of the gastroc, I'll use my other thumb and cross over to that side. So on the lateral part of the gastroc, I'll use this hand, go in deep enough to grab the muscle, and then use all 8 fingers to twist my hand and drive the thumb up like this. Notice that I'm keeping my wrist down. If I let my wrist come up at all, this contact is going to get pretty pointy, and it's going to be very uncomfortable, and I just won't be able to do it as hard as I need to fix the problem. Flat contact, use my fingers, plantar flex, get my depth, take my tension, dorsiflex. The patient can usually do as much dorsiflexion if you need. If you need to, you can assist by using your knee and just adding a little dorsiflexion as you go. So I'll work the bulk of the muscle this way. To get the very top of it, what I'm going to do is flex the knee, use a thumb, generate tension proximal, right in behind the knee, and then extend the knee all the way, and then dorsiflex the foot while I maintain a proximal tension with my hand. Once the patient gets that idea, they can do that actively, and I can use both thumbs, although usually you'll have enough strength with one hand to do that. Now you'll be missing the last part of extension of the knee in this position here, so what we'll do is we'll put the knee and the patella just off the table a little so the patella doesn't get compressed. And we'll start here. This way, with the leg just off the table a little bit, I can get a little extra extension of the knee, and then dorsiflexion of the foot will be the same. During extension of the knee, the gastroc and the hamstring have to slide in opposite directions. So during a flexion and extension, they have to make opposite slides like this. So if that's a problem, what we're going to do is we're going to flex the knee and plantar flex the ankle, and then put a thumb right in between the medial side of the hamstrings and the lateral side of the head of the gastroc. And I'll take a tension proximal, roll my thumb right in between the two muscles as much as I can, then extend the knee, and then dorsiflex the foot. And then force my thumb in between the two muscles so I ensure that those two muscles slide. I'll also need to do the medial side as well. So you've got the medial side and the lateral side between the gastroc and the hamstrings. The plantaris is a relatively small muscle that not everyone has, but especially in an athlete like a long-distance runner, when it does shorten up and become a problem, it'll give you symptoms of pain down the back of the calf a little bit on the medial side into the Achilles tendon area in this area here. So the muscular portion is relatively short here. It's oriented just like the popliteus muscle. So I'll pull the tissue, the more superficial tissue lateral just a little bit, and then go in deep to the plantaris muscle. I'll flex the knee and then internally rotate the tibia and plantar flex the ankle. Take my tension superior and lateral along the muscle, and then extend the knee, internally rotate the tibia, and dorsiflex. Most of the treatment will be in the muscular portion here, but once in a while you'll find that this tendinous portion that blends in down this area, you'll also need to treat that part down here. When you get down to this lower section, the external rotation of the tibia won't be very important. It's mostly going to be extension of the knee and dorsiflexion of the ankle. The soleus muscle is often shortened and tightened in people that have to stand and work all day, but really anyone can get this problem. If the gastrocnemius isn't too tight, I can go through it. This prone position gives me the best leverage, but I'll have to go through the gastroc. So I'll start with plantar flexion. The toes are not necessarily flexed, but they won't really interfere. I'll take my thumb contact with either hand, depending on which side of the soleus I'm working on. If I'm working the lateral side of the soleus, I'm going to use this inside hand. Penetrate through the gastrocnemius to the soleus muscle, then take my tension, and then dorsiflex the ankle, and if need be, I will assist that. Go ahead and stand in. It can also be treated with the patient in the kneeling position here in order to get less tension on the gastroc. I still have good leverage here though. So I'll have the patient plantar flex, take my contact through the gastroc, switch to tension, and then dorsiflex, assist the dorsiflexion if necessary. To treat the tendinous arch of the soleus, I'll have the patient prone. It can be done kneeling. It's just a little easier to do it prone. And I'll use an inferior tension. The arch of the soleus is going to be just a little bit on the medial or the inside of the knee. So I'll find the upper edge of the soleus and then make sure I'm off the vein, artery, and nerve, so either side of that, and take an inferior tension. Start with the patient ankle plantar flexed, and then dorsiflex while I maintain an inferior tension, stretching the arch of the soleus. And I'll make sure I treat both sides of the vein, artery, and nerve, but on the tendinous arch. The popliteus muscle on the back of the knee is very important in stabilizing the lower leg in rotation. We'll treat that by starting with the knee flexed, the tibia internally rotated. As far as plantar flexion and dorsiflexion, it won't really matter, but if I maintain a little bit of plantar flexion, I'll keep the gastrocnemius relaxed, and it'll be easier to palpate the muscle as we go. I'll start on the medial side here and take my tension superior and lateral into the bulk of the popliteus. And then I'll extend the knee and externally rotate the tibia while I maintain that tension up and across the knee. You'll find that you'll have to treat the medial part, medial to where the nerve is, and then the lateral part, lateral to where the nerve is. At the very end, you may consider reversing your tension and going inferior medial up to where the vein, artery, and nerve are. To work the capsule of the knee, we'll start with the patient seated. We have to work all sides of the capsule. Most of the problems will be felt mostly along the attachment on the tibia, so there'll be a tender line on the attachment of the tibia. So we'll make sure we start there with our tension. We'll start an extension and when working the anterior part of the capsule. Start here, start right on the attachment point on the tibia, and then roll the thumb so that we generate a tension proximal. Then have the patient flex the knee all the way while we exert a very firm tension along the capsule. And then we'll go all along the whole front of the capsule, lateral to medial side, doing the same kind of tension proximal on that. Once we've done that across the front, we'll have the patient lie supine. And then what I'm going to do is use this position to more thoroughly analyze the medial and lateral part into the posterior capsule. So then I can start here and flex and extend the knee to find out where the capsule tightens up the most. For example, the capsule tightens the most here when I extend the knee just posterior to the medial collateral ligament. So what I'll do, start with a little flexion, take my tension on the posterior capsule just posterior to the medial collateral ligament, and then extend it while I maintain the tension. And then I'll externally rotate, internally rotate. I find a little more tension with externally rotate, so I'll finish off by externally rotating and maintaining that tension. So you see you've got several motions to consider. The main are flexion and extension. Find the spot that tightens up the most, whether it's flexion or extension, put it in that position, whichever is the tightest, then check internal and external rotation, find the spot where it's the tightest, put that in its position, and then stretch on the capsule. It's difficult to work the posterior capsule, but in this position I can use two fingers and get fairly close to the posterior capsule if I work my fingers in between the popliteal vein, artery, and nerve and the head of the gastroc, and then work my way between those structures as much as I can, and then use an inferior tension and stretch loose. That can be done prone as well, although you'll find that you won't be able to exert a whole lot of depth and tension just because of the structures around on the posterior side. Fortunately, most of the problems are going to be on the anterior side because that's where most of the motion has to occur. Most of the stretching will have to occur on the anterior side. The medial and lateral meniscus are very important to work correctly and to analyze correctly. They have to have some give and some slide along the femur, the femoral condyles, and the tibia. What we're looking for when we analyze this is that lack of slide. When the meniscus doesn't slide very well, you'll find that at full extension or rotation or flexion and rotation, it'll get trapped and pinched, and that's when it's vulnerable to getting torn. So if you have a patient that there's pain along the joint line, or it clicks and pops, or it feels like it's ready to lock when it's fully extended or fully flexed, those are indications that this is a problem. So we have to have a system. So what I'm going to do is I'm going to start with my thumb right in the notch over the medial meniscus, and I could pick the posterior medial meniscus, the anterior, or the anterior lateral meniscus, or the posterior lateral meniscus. I need to do all four, but I'm going to start with the anterior medial meniscus because it's the easiest to find, and it's very easy to just drop my thumb in kind of sideways a little right into the joint line. Now, I'm going to divide all the motions up and solve or eliminate half the possibilities with each step. So I'm going to check full extension. I'm going to hold my thumb on the meniscus and just see how it slides and moves at the end of the range of motion. So I have a firm tension right on the meniscus, and right at the end of extension I'm going to assess how it moves and slides on the tibia and the femur. And then I'm going to check that versus flexion all the way, and I'm just going to push it into flexion a little bit and see how it slides and moves. Now in this case it's a little bit stiffer or less movement when I move it into extension, so I've eliminated all the flexion problems. So I'm going to hold it in extension, and then I'm going to add external rotation and internal rotation, and I'm going to feel for which way it moves the least. In this case, with full extension and then external rotation, it moves the least. Now I can add varus and valgus, but it won't do that much for it. So the main things are flexion, extension, and internal and external rotation. So I'm going to hold it in extension, hold it in external rotation, and then I'm going to push the meniscus right along the joint line until it starts to give way and slide better. Once I've done that, I'll unlock it in both positions. I don't have to go all the way through it, but just get it unlocked, and then push it to full extension again, push it to full external rotation again. It should move a little farther this time. And then push the meniscus again until it starts to slide. And I'll do that enough times until I get that meniscus to slide when I'm locked in extension and as much external rotation as I can comfortably get for the patient. Once I've done that, I have finished the anterior medial portion. Now I need to go and check the posterior medial portion and the anterior and posterior lateral portion. When I get to the posterior medial portion, when I can analyze it fairly well by just holding my thumb in here and checking extension versus flexion. But once I get to the rotation, it gets a little awkward on this side. So most likely it's going to be a little easier if I put my hand on the inside and then move my fingers out of the way enough to get full flexion. Check it here with a little anterior pressure against the meniscus, then check it in full extension and see which way moves the least. The most awkward to do is when it's extended, so I'm going to demonstrate that. So let's say it moves the least in extension. I'm going to sit near the end of the table so that when I rest her leg, the ankle is on my knee. That way it's easiest to extend the knee. So I'm going to drop the knee into full extension, and now I feel that the meniscus is a little stuck and doesn't want to slide very well. So I'm going to hold it in extension. Then I want to internally and externally rotate the tibia. So once I start to rotate it, though, it's going to tend to want to flex because I'm pushing the meniscus forward. So what I want to do is hold the knee down with this hand and then use my elbow here, just dorsiflex just a little bit, and I can hold the knee in extension by holding the knee down with both hands, push forward on the meniscus, then externally rotate the tibia, put my elbow on the other side, and then internally rotate the tibia. Now in this condition, when I get it fully extended and internally rotate, I feel the most tension on the meniscus. So I'll fully extend, then fully internally rotate, and then push the meniscus until it starts to slide. Unlock the joint, go to full extension, full internal rotation, then push on the meniscus again. Do this 3 or 4 times until I get that meniscus to slide. So in that manner, I'll do all 4 sides. So I've got the posterior and anterior medial meniscus, posterior and anterior lateral meniscus, so I'm pushing forward on the meniscus sometimes and posterior on the meniscus sometimes, and I've checked all the combinations of motion. Has to be a system like that or guaranteed you'll miss one of those motions and directions. The lateral joint line is more difficult to palpate. So finding the lateral meniscus is a little more difficult than the medial side, but I'll flex the knee to about 90 degrees, and in that position I can put my thumb on the joint line. So then I'll check full flexion and full extension and feel which way, in which position the lateral meniscus moves the least. I'll do the same thing, then I'll go to the posterior part of the joint line, push forward on the meniscus, and analyze extension and flexion. Now the most difficult part is to work the posterior lateral meniscus in extension. So let's demonstrate how to do that. We'll just drop this other knee off the table, and I'm going to demonstrate on this leg. But let's say it's in extension, so I'll have my hand in here, and then I'll sit near the end of the table, drop down so that her ankle's on my leg down here, so I can hold it in extension again like this, push forward on the meniscus, and then use my forearm and elbow to externally rotate the tibia and internally rotate the tibia. When treating the medial and lateral collateral ligaments, once in a while you'll find that they're shortened, but usually they get a little too loose. Probably the most common problem is that they don't slide anterior and posterior with knee flexion and extension. So in order to reinforce that, what I'll do is I'll start with the knee flexed, come around to the posterior side of the medial collateral ligament, go anterior against it, and then proximal along it with the knee flexed. Then I'll maintain that tension and position and extend the knee with the anterior pressure and proximal pressure on the collateral ligament. That way I'll make sure that it has a little give or a little slide over the femur as that extension takes place. And I can do the same thing on the lateral collateral ligament. I can use either hand here as I do that and make sure that there's a little give between the collateral ligament and the femur as this motion takes place. Once in a while you'll find a patellar tendon problem, and often the problem is deep within the tissue of the patellar tendon. When it involves pain, it's usually at the attachment at the tibia, but once in a while, especially post-surgically after a knee reconstruction or a tendon surgery, you'll find that it's sensitive and non-resilient in the tendon itself. The easiest way to palpate and find where the problem is to have the patient supine, bend the knee about 90 degrees, and then I'll use both hands like this where I can squeeze and turn with my fingers and just push my thumb into the depth of the patellar tendon and then roll it up like this and palpate the inside, the deeper fibers in the patellar tendon, and feel where I can find a non-resilient, hard, or scarred portion. Once I find that, I'll have the patient lay prone. Because the treatment of this requires a little bit of pressure, it's easiest to work it in this position. So I'm going to have the knee partially flexed. So I'm going to come across like this as much as I can. It'll feel a little awkward in this position, but I want my feet about where they are so that when I get back in this position, I can lean straight into the tendon. So lean over, and I've got my forearm along the tibia. So I can flex the knee by pushing with my forearm along this. Now I've got a lot of leverage there, and if there's a problem in there, I have to be careful not to push too hard on this because there is so much leverage. So I'm going to push a little bit lightly with this, but I'm going to go extremely hard with my thumb. So I've wrapped around the lower leg, and I'm going to use one thumb behind the other, go deep into the tendon first, and then add my tension. Start here with as much extension as I can get. I can't get too much. And then as I flex the knee, I'm going to use my body weight right onto the tendon, roll my thumbs into it, and then use my forearm to flex the knee as far as it will comfortably go. In this position, I've got a lot of authority on the patellar tendon, which you will need to get that deep on that tough tissue. The vastus medialis is very important for patellar tracking problems and extension of the knee, obviously. It's very important to make sure that the fibrous nature of the vastus medialis, when it gets that way, is released so that it can provide proper patellar tracking. So we'll treat that most easily in the seated position and the sideline position. We'll start in this. I'll wrap my opposite hand around so that my broad hand is on the vastus medialis, which is right here. I'll take my contact with this hand, back it up with this hand, use the fingers to twist and draw tension proximally, and then the patient will flex the knee, and as soon as they can, grab the ankle and pull the ankle back so that they're not using the hamstrings to flex the knee at the end. In the seated position also, the hamstring will be less likely to cramp, so seated works very well. Go ahead. And then make sure that they lift with their hand instead of the hamstring to flex the knee all the way. Now, in the sideline position, let's have you lay on your right side. The one we're treating will move to the back side of the table here, and we'll have the other leg on the front. But I want to make sure the pelvis is about perpendicular to the table like this. If you let the patient roll over, which is what they'll try to do, when you bend the knee, it's going to be up in the air, and it's easy to apply a leverage across the knee, which you don't want. So make sure the pelvis is vertical on the table. And then I'll just bend it very slightly, and I'll take my contact on the vastus medialis with this hand, wrap my thumb around. I can back it up with this hand to provide the pressure, but this thumb remains very soft. Take my tension and then have the patient just start the flexion and then relax, and I'll provide all the flexion force, so you're not using your hamstring. Just relax the leg, and I will push the knee into flexion by moving my leg against the ankle here. The vastus lateralis is actually a little wider than most people realize. It goes all the way back to here around the femur. So we've got a lot of space to treat, and then we have the IT band coming down the middle. It's important not to just end your treatment when you get to the IT band. You need to actually go posterior to the band to finish it off. So I've got a lot of area from here to here. I'll start with the knee extended, take my contact with the opposite hand, use my fingers, this hand to supply a lot of the force, squeeze with my fingers, and then drive the thumb up to get the tension. And the patient, as soon as they can, will grab the ankle so that the hamstrings aren't cramping trying to flex the knee. Also, with the patient seated, the hamstring will tend to be a little bit longer, so cramping will be minimized. And then with each pass, we need to make sure that I cover the entire width and length of this muscle, all the way up to here and all the way back to here. Okay? And then all the way up high up into here to finish it off. The best mechanical leverage in working the rectus femoris is with the patient seated and I'm standing next to the table. With the knee just off the side of the table, I'll have the patient extend the knee, and I'll use this hand to compress right into the rectus femoris, and then use my fingers once I'm compressed deep enough to draw tension superiorly. I'll use this hand to supply a lot of the force, soft right thumb contact, and then the patient will bend the knee and as soon as they can, they'll grab the ankle to pull it up so that the hamstring doesn't cramp. Once you've loosened it up, but you need more motion to finish it off, you'll start the same way. Grab your tension, flex the knee, grab the ankle, and then have the patient lie down to continue that stretch in the rectus femoris. Once it's there, if they can flatten out the low back, that will even stretch it out more. Okay, go ahead and sit up. Lie on this side. To get full range of motion of the rectus femoris, once you've done the bulk of the work the other two ways, this method will get full range of that rectus femoris. So I'll start with the muscle short by flexing the hip and extending the knee. I'll take a contact in the middle of the rectus femoris, use my fingers to generate some tension on the muscle, and then I'll extend the hip by walking around. Then I'll put the ankle right in my hip and start flexing the knee. Now I'm going to hold the pelvis this way so that the patient doesn't roll back off the table. And I'll do a combination of extending the hip and flexing the knee, but probably both not at the same time, because you'll reach the end of the range of motion fairly soon for most people. So once you get to the end of the range of motion, then just do one or the other. Usually do the hip extension first and then add a little knee flexion until you get the end of the range of motion. And in this position with my body, stabilizing the hip here, I'm going to lean over and get kind of close, so my shoulder's down close, because I need to generate a lot of tension proximal on the rectus femoris in this position. Be careful to go relatively easy with the leg and the knee flexion, but very firm with the tension on the rectus femoris by leaning into it this way. Once in a while you'll have to reinforce that sliding motion between the rectus femoris and the vastus intermedius. In order to do that, we'll start with the patient seated, extend the knee, and then I'm going to take the rectus femoris, I'm going to put my thumb on the medial side of the rectus femoris and push it over lateral so that I expose the vastus intermedius. It's much easier going this way rather than coming from the lateral side. So I'll push the rectus femoris lateral till I expose the vastus intermedius, and then use a proximal tension with my thumb in between the two muscles. Then the patient will flex the knee and grab the ankle, and then lie back down. so that I've got the vastus intermedius going distal and the rectus femoris going proximal at the end of this motion. To work the vastus intermedius, I either have to go through the rectus femoris or move it out of the way. Let's move it out of the way, and we'll move it from medial to lateral to expose the vastus intermedius. We'll start with the knee extended. I'll take my thumb on the medial side of the rectus femoris and then move it over lateral, then use my fingers to take a tension proximal on the vastus intermedius. Then the patient will flex the knee and as soon as possible grab the ankle and pull it up to the knee in full flexion. With the patient seated, it'll minimize cramping on the hamstrings. Push the rectus femoris lateral, compress against the vastus intermedius, then take a tension, and then the patient moves the knee. The articularis genu can be a troublesome small muscle. It positions a bursa at the proximal pole of the patella. So in order to get that, we have to be careful to stay close to the patella until the second half of the motion. If I just start here and then take a tension, then move the knee, by the time I'm halfway flexed, I'm already past the muscle, because the muscle's only about this long. And if I just take my tension indiscriminately, I'll be past that muscle and I'll never effectively treat it. So they'll still have that pain right at the tip of the patella. What I have to do is place my contact and not take a tension right at the proximal pole of the patella. So I'm going to put my thumb there, but I'm not going to take any tension at all. I'm not even going to go like this and draw the skin tight, because that will just make the treatment painful if I have the tension on the skin. So just lay my thumb right in the proper area. Now, as the knee starts to flex, we'll go slowly here, I'm actually moving my thumb down to go with the patella. And when I get about a third of the way, the patella will start to expose the articularis genu as it moves inferior. So when I get about a third of the way, then what I'm going to do is roll my thumb and try to get in behind the patella. And then when the knee is about 90 degrees flexed, then I'll take my thumb with it behind the patella like this, then I'm going to roll it like that to generate tension on the articularis genu. So no tension. Okay, bend, roll in behind the patella. Still, my thumb is moving inferior. Now, about halfway, then I'll roll the thumb in and then start to go proximal and pull on the articularis genu. It'll have a very different feel to that if you actually get to the muscle this way. And that will effectively reduce that problem. The adductors are very thick muscles. We're going to treat them generally as a group, but it's very important as you do this, no matter where you're taking your contact, on the front side of the adductors or the back side getting mostly the magnus, you have to be careful to use a flat contact and go very deep before you draw your tension. If you draw your tension on an angle like this, it'll just sting and be very uncomfortable, and you won't be able to effectively get to the deeper parts of the muscle. So to start off, I'm going to go on the back side of the adductor. Start with the adductor as short as I can in this position. Go deep with two hands, take my tension, and then move the hip into abduction and flexion as far as it will reasonably go while I maintain a proximal tension on the muscle. I can use one hand, be on the front side or the back side of the adductors, go in and then guide the motion with my opposite hand so I can control the knee. Or if I need more strength and depth, I can use two hands on any of those positions. Now, in particular, the most proximal part of the adductor magnus on the back side, if that becomes a problem, you'll usually get a twisting of the pelvis and sometimes an osteitis pubis. If that's the case, you need to get full flexion of the hip to get the back side of the adductor magnus on the proximal end. So what we'll do is I'll take a tension with this thumb, and I can be on either side of the tibia. I'm going to be on the outside of the tibia so you can see better what I'm doing. So I'll go very proximal near the attachment on the back side of the adductor magnus, and then I'll flex the hip all the way, and then I'm right up against the attachment. Then I'll put my hand in here so that I can just pull my body down, and what I'll do is I'll extend all the way to maintaining a very firm contact, proximal and then across the attachment where it attaches on the ramus of the pubis. That will usually resolve that short little area right where it attaches. Once in a while you'll have to get a proximal attachment treated, and the way you'll do that is you'll follow the attachments all the way up to actually where it attaches on the ramus of the pubis, and then you'll take your thumb and you'll roll this way to get tension on the sheath and that proximal attachment. If you just move your hand this way, you'll irritate the sheath and you won't effectively treat it. But if you just roll your thumb, you can actually get quite a bit of pressure on it without irritating the tissues. So I'll start with the tissue a little bit shortened, take a contact, and then as I move, I'll roll my thumb and then use a distal firm tension with full motion as I take the knee out so the hip is flexed and abducted. My thumb doesn't move very far, but it's quite a bit of tension actually on the sheath as you do that. Once in a while you'll have an adductor problem that's interpreted simultaneously by the person as a groin pull or a hip flexor problem. The reason for that is when the hip is fully extended, the adductor actually flexes the hip. So in a runner or a skater that gets the leg all the way out or all the way back or both, when they first start to bring the hip into flexion, this front part of all the adductors has to do a good deal of that pull. The only way you'll finish off treating that is to put it in that extended position at the end of the motion. So what we'll do is I'll take a contact on the front side of the adductor, go proximal near the attachment, and then extend the hip and abduct. Once I'm in this position, what I'm going to do is either step in or move my hand into the inside and go ahead and push the knee down into extension so the hip actually extends a little bit more than neutral. And then if I need to, I will also abduct. So I can move the knee out this way and then keep extending until I feel a good tension on the anterior proximal part of the adductors. For most muscles, as long as you start at the shortened position and end at the lengthened position, you're going to be okay in treatment. But the sartorius is not that way. The reason it's not that way is it's almost impossible to get the femur to internally rotate unless you set it up halfway through the treatment before you finish it off. So what we'll do is we'll start with the sartorius in the shortened position like this. Now the sartorius runs from here to there, and it's on this medial side of the vastus medialis. It's actually quite easy to find once you think about where it goes for a second. So I'm going to take my tension on the posterior side of the sartorius and then go right on it and pull it proximal. But I'll start in this position right here, then take my tension on the sartorius proximal. Now, the first thing I'm going to do is I'm going to leave the knee about 90-degree flex. So I'm going to start flex and just leave it to about 90, and then abduct and extend the hip till it's fully abducted and extended. Then I'm going to internally rotate the femur with the knee still at 90 degrees. If I straighten out the knee right away, I don't have enough twist available by grabbing her ankle to do that. So I'm going to hold the hip in extension and abduction and then internally rotate as far as it will go. Once it's there, I'm going to maintain the tension on the sartorius and then extend the knee. Once the knee is fully extended, you'll notice that the knee will try to come up like this. So once it's fully extended, just make sure you have the hip extended and abducted all the way, and you'll feel good tension on the sartorius. Now the adductor canal is the same motion. The only difference in the treatment for the adductor canal is instead of being right on the sartorius, I'm going to try to move the sartorius out of the way and get underneath of it so that my thumb actually goes into the adductor canal with a proximal tension. Other than that, it's the same motions. So I'll start here, Move the sartorius out of the way, hold it out of the way, get into the canal with a proximal tension, then abduct and extend the hip, then internally rotate the femur, let the knee stay 90, and then extend the knee once I'm in that position, and then make sure I've maintained the hip extension and abduction. Most of the drainage for the lower leg for lymphatics goes through the hiatus of the adductor, so it's important to understand how to release that so that the lower leg lymphatics can move properly. We'll start with the knee mostly flexed, just to take the hamstrings out of the position. And then I'm going to take my thumb and just slide right over the vastus medialis and then drop right into the front side of the adductor. And if I do that just proximal to the knee, my thumb's going to go right into the hiatus of the adductor. Once I'm there, I'll just drop right into the hole and then take a proximal tension and then move the adductor so that it tensions appropriately. Drop in, move out. When you treat the adductor canal, you're going to go right over the vastoadductor membrane. But we're going to add one thing at the end to make sure that the vastoadductor membrane lets go so it's not too tight. What we're going to do is we're going to start with the knee extended, and I'm going to just move the sartorius out of the way a little bit again, get into the adductor canal, and then in this position here between the vastus medialis and the adductor, I'm just going to hold my position. Now I'm going to adduct to get the adductor tight. The adductor generally is moving this way from my contact because of the pull from the hip. And then I'm going to move the vastus medialis distally by flexing the knee while I hold that position with my thumb with a proximal tension. So the adductor first goes this way, vastus medialis goes this way, and you'll stretch the vastoadductor membrane in this manner. The gracilis is superficial, so we have to be careful on not taking our tension before the compression. Otherwise, it'll feel stingy and you'll pull the skin. It's very sensitive and you won't be able to release the muscle. Well, we'll start with the gracilis relatively short by flexing the knee and leaving the hip in adduction. We have a little flexion which will stretch it a little bit, but it's relatively short in this position. So we'll pick our spot right on the gracilis. I'm going to pick this spot right here. We'll trap it in this part of my thumb, so it's not on the tip. I'm just going to kind of surround it like this. So I'm pulling a tension right in the hook of the thumb. And I'll get deep enough to grab it and then use my fingers back here to pull down with my fingers and up with my thumb to generate the tension. Once I've generated that tension fairly deep, then I'll move the hip into flexion and abduction and then extend the knee. When you extend the knee, be careful. You may actually have to let the hip flex or extend just a little bit until you've got full knee extension without excessive tension on the gracilis. So you'll treat the entire length of the gracilis. It may be necessary at the proximal end to actually do a reverse tension, so you're distal, just right at the proximal end, rolling your thumb on the attachment site itself. It's important to obtain a relative motion between the adductor and the gracilis. In order to do that, we're going to make the adductor go one way and the gracilis go another way. We'll set that up by standing on the inside of the leg and moving the hip as close as we can to the leg to the midline. And I'm going to put my thumb on the medial side or the posterior side of the gracilis, kind of push it anterior just a little bit and get in between it and the adductor group. And then I'm going to take a proximal tension. Now, the first thing I'm going to do is flex the hip and keep the foot close to me here, so the gracilis is relatively relaxed, but the adductor is tensioning proximally with respect to my contact point. So now the adductor is going that way. Once I get the adductor fully tight, my thumb's in between the two muscles, and then I'll make the gracilis go distal by extending the knee, and I should feel that gracilis pull distally against the side of my thumb as I go. There must be a relative motion or sliding between the semimembranosus and the adductors as well. So in order to do that, we're going to do a similar motion as some of the other treatments. We're going to make the adductor go one way and the hamstring to go the other way. Relative to my contact position, I'm going to have the adductor go proximal, and then at the end I'm going to extend the knee so that the hamstring goes distal. Now we'll set that up by being on the inside here, and I'll put my thumb in between the semimembranosus and the adductor magnus in any of the spots that I feel are the most restricted. I'll put my thumb in between the two muscles and then exert a proximal tension. I'll start in this position here and then flex and abduct the hip so that the adductor goes that way, and then once I'm there, I'll extend the knee and I'll feel the semimembranosus pull distally as I go. The pectineus and obturator externus basically lie one on top of the other. The pectineus is a little bit inferior to the obturator externus, but it is deeper. The obturator externus is deeper. So we'll treat one, and then we'll move our contact superior just a little bit, but go a little deeper to get the obturator externus. The motions for the patient are the same, though. So the easiest way to find this is start with the gracilis in the adductor tendon right here. Go fairly close to the ramus of the pubis, put my thumb on find the gracilis in the adductor tendon, and just drop off of that, and then in this little depression right in here, you'll be right on the pectineus. Don't go too far lateral, or you'll find the femoral vein, artery, and nerve. So just right off the tendon, right into the sulcus right here, and then I'll take a medial tension. So I'll grab the ankle here, and I'll have my arm available to push on the tibia and the knee. Take my contact, medial tension, and then flex the hip, then abduct, and then hold the knee down and raise the foot to externally rotate the femur while you maintain a medial tension. For most muscles, as long as you start at the shortened position and end at the lengthened position, you're going to be okay in treatment. But the sartorius is not that way. The reason it's not that way is it's almost impossible to get the femur to internally rotate unless you set it up halfway through the treatment before you finish it off. So what we'll do is we'll start with the sartorius in the shortened position like this. Now the sartorius runs from here to there, and it's on this medial side of the vastus medialis. It's actually quite easy to find once you think about where it goes for a second. So I'm going to take my tension on the posterior side of the sartorius and then go right on it and pull it proximal. But I'll start in this position right here, then take my tension on the sartorius proximal. Now, the first thing I'm going to do is I'm going to leave the knee about 90-degree flex. So I'm going to start flex and just leave it to about 90, and then abduct and extend the hip till it's fully abducted and extended. Then I'm going to internally rotate the femur with the knee still at 90 degrees. If I straighten out the knee right away, I don't have enough twist available by grabbing her ankle to do that. So I'm going to hold the hip in extension and abduction, and then internally rotate as far as it will go. Once it's there, I'm going to maintain the tension on the sartorius and then extend the knee. Once the knee is fully extended, you'll notice that the knee will try to come up like this. So once it's fully extended, just make sure you have the hip extended and abducted all the way, and you'll feel good tension on the sartorius. Now the adductor canal is the same motion. The only difference in the treatment for the adductor canal is instead of being right on the sartorius, I'm going to try to move the sartorius out of the way and get underneath of it so that my thumb actually goes into the adductor canal with a proximal tension. Other than that, it's the same motions. So I'll start here, move the sartorius out of the way, hold it out of the way, get into the canal with a proximal tension, then abduct and extend the hip, then internally rotate the femur, let the knee stay 90, and then extend the knee once I'm in that position, and then make sure I've maintained the hip extension and abduction. Of course, it attaches to the iliotibial band, and it's very important for stabilizing the knee. So if you find somebody who says their knee kind of wobbles and it feels a little unstable, you really need to check the tensor fascia lata. It's the most superficial muscle in this portion of the hip, and it's between the trochanter here mostly and the crest of the ilium here. So I'm going to take my thumb and kind of surround it. I'm going to grab just below the knee and flex the knee and kind of hold the pelvis so that the patient doesn't roll back. And I'm going to abduct and flex in this position. But I need to stabilize the pelvis, because when I bring the hip into extension, they're going to want to roll back, and you don't want them to do that. But start in this position here so the TFL is completely short. Then I'm going to take my depth right into the muscle and roll my hand and take a proximal tension like this with my hand. So it's fairly strong, and I'm not putting undue pressure on my thumb. And then I'm going to adduct and extend the hip and extend the knee. Then I'm going to move my hand just above the knee and push into adduction and extension. So I'm pushing this way on the femur, not the knee itself, while I maintain a proximal tension on the TFL. Now, I can also do a distal tension if I need to get the attachment, the fascial attachments on the crest of the ilium here. So I'll get them to relax, and I'll support the whole weight of the leg. You need to get them to do this, because if they're holding the leg up, that TFL is contracted and it's going to be too sensitive to get in hard. So wait until they'll really let go and relax. So flex the hip, abduct, flex the knee, take a distal contact. On this one, I have to maintain my body position back here so I can just lean into that contact a little. When I get to this position, I'll move my hand above the knee, push into adduction and extension, and a distal tension this way with my hand right in my hip so I can get some force on there without needing too much strength. The iliotibial band is long and flat, and it sometimes can be difficult to work because it sits right on top of the vastus lateralis, and where the femur bows out, you've got the IT band and the vastus lateralis and then the femur right there, and it's very difficult not to compress it against where the femur bows out and cause a sensitivity problem. So we're going to start just by using the palm of my hand here, and I'm going to place that over the IT band and push with a very, very broad contact in on the IT band enough to grab it, and then push it proximal, and then adduct across the body. Now, as I adduct, it's important to maintain my tension not this way, proximal, and not let it go to 90 degrees and push straight into the femur, because you'll pinch the joint in here or compress against the femur here. So change your angle and just use a general tension on the IT band this way. Now, once you've done that, if you could lay on your left side, you can work the bulk of the IT band starting in this position, and then take a proximal contact, and then extend the hip and extend the knee and adduct while you maintain a proximal tension on the IT band. Again, it's very important in this position not to use this part of your thumb or the tip of your thumb and compress too hard against the femur. What you want is curve your contact, general contact, and then maintain your proximal tension. Then you can get tension on the IT band in this way. And I'll work from here to here using that method. Now go ahead and sit up. To work the most proximal or distal end, scoot back just a little bit. What I'll do is I'll just use knee extension to do this. During knee extension, this attachment of the IT band, it kind of slides forward on the femur. And I want to make sure it slides forward, or anterior. I'll put my hand behind the IT band, start with the knee 90 degrees flexed, take my contact behind the IT band, push anterior and a little proximal, and as the knee extends, I'm going to make sure that IT band moves anterior with proximal tension. Start there, extend the knee, and make sure it moves anterior a little bit while I maintain a proximal tension. As a runner goes faster and faster, there comes a point where the vastus lateralis and the IT band will have to do some sliding in opposite directions. So we're going to reinforce that sliding. We're going to trap the IT band in its relatively lengthened state, but we're going to trap it so that it's tension proximal and then move the vastus lateralis distal. So we'll start in this position here, take a contact on the IT band against the vastus lateralis, and then I'm going to move the hip into extension, the knee into flexion while I maintain a real firm contact. I'm going to hold the pelvis here anterior so it can't roll back. I'm going to extend the hip until it stops, and then flex the knee until it stops, and then adduct the hip as far as it will go. As I adduct the hip, I'm not increasing hip extension, and I'm definitely not increasing the flexion of the knee. It won't go that well, and then the patient will arch the back and resist the motion. So extend till it stops, flex the knee till it stops, and then adduct as far as you can and push the IT band proximally. As you adduct, it's important to lower the patient's lower leg as well. If I maintain this foot and ankle up here and just push this down, I'll internally rotate the femur, and that'll get quite uncomfortable. Sometimes when we try to get very detailed and we're worried about the smaller hip rotators, we forget about the big muscle, the gluteus maximus. Obviously, it needs to be treated. It's usually not a matter of a very, very local pain. It'll be more of a general pain unless it's right at the attachment on the linea on the femur. But to get to the bulk of the muscle, we'll just place a general contact in this area with our tension this way, use my fingers to grab and twist like this, and then I'll move the knee into flexion, which isn't important for the muscle, but I'll move the hip into flexion. Now I have some options here. One is to just put the foot on your femur and just lean in so that the hip goes into flexion here. On the glute maximus, this is a good way to do it. It keeps you in a position that gives you some authority, just leaning into it very well. And then you want to make sure that you finish off by getting the most distal portions right in here. So I'll step over here and make sure that I get this portion that's right against the linea on the aspera. Or on the femur. So I'll start here, get right on the line of attachment. It goes pretty low all the way down to here. And in elderly people, especially that sit a lot, you'll have a real sensitive line right on here. So you won't resolve the glute max problem until you get this. So I'll take my tension right along that line of attachment on the femur, move the hip into flexion, kind of lean into it here, to use both hands to get some tension, and then if I need to, I'll go ahead and push the knee down to adduct just a little bit more. If I can't adduct that well enough, what I'll do is have the patient lay supine, and to get that spot on the femur, I'll just go in this position here, flex, and then just lean on the femur to get it to adduct. You have to be careful in this position because it's easy to push too far and you'll pinch the joint on the front side. So be a little bit judicious on how far you take it across. More flexion's okay, but this 45-degree angle motion here will tend to pinch it on the front if you go too far. You may need to treat the proximal attachment with a reverse tension. So lay on that side again. In that case, I'll just pick my point of attachment here wherever it's tender or tight or fibrotic. Use a distal tension and have the patient flex the hip and maybe adduct or move the knee across the body. Not quite so much flexion, just move across to adduct more. If you have them flex completely up against the body, they won't be able to adduct. So if you do need adduction, just limit the amount of flexion just a little bit. the quadratus femoris is not as difficult to find as you might think. If you move the hip in a position where it's very easy to feel the trochanter of the femur in the hip, if you go off the posterior side of the trochanter on maybe the inferior side of the trochanter, and then just go straight down towards the sacrum and the coccyx, straight down towards the table, you'll be right on line with the quadratus femoris. So what I want to do is have the knee flex just slightly, and I'll push straight down in on that muscle, flex the knee to about 90 degrees, and then I'm going to put my knee on the side of the patient's knee, and I'm not going to push down. I'm just going to hold it there so that it doesn't go down and doesn't come up. And then I'm going to internally rotate the femur by raising the foot, and you'll feel that quadratus femoris push right against your thumb while you maintain that medial tension. The superior and inferior gemellus and the obturator internus can all be worked in a similar manner. It's just a matter of where your thumb's going to be, and a very slight difference in where you put the hip flexion to be on line with one of those muscles. But in general, they're all the same. So we'll start with the patient's side lying with the hip in a relatively neutral position, and I'm going to take a contact from the trochanter on line with those muscles medially, almost straight medially. And I put my hand flat on the side of the hip and use my fingers to turn and generate tension with my thumb. Then I'm going to have the patient with the bottom knee bent so they don't feel like they're going to roll off the table. I'm going to have them bend the hip and the knee, bring the knee up right along the edge of the table so it touches, and then grab the knee with your hand and pull it all the way forward along the table without rolling over on the table. So you get as much as you can the hip flexion and adduction as much as the patient can do themselves. Okay, go ahead. And then I'll maintain a tension on these muscles. You may find on a larger person that if you need more authority, you can straddle the table this way, then have them move, and now I'm just on top of it. I can really exert more pressure on the muscle as it goes. Now, if you don't have someone to assist and you need more rotation at the end, what I can do is I'll start in this position here. I'll maintain my contact with tension medial and then have the patient do that same motion right to there. And then I'm going to put my foot right on the side of her ankle, and my tibia is right along her peronei and the fibula. And I can control the knee flexion of the hip, and to some extent how much adduction there is. But I'm going to put the hip in just over 90 degrees of flexion, and then I'm going to rotate the femur by pushing the foot down without continuing to push the knee down. Then I can rotate with quite a bit of authority doing that. Now you may find that depending on how high the table is and how far away you are, how big your arms are, you can use either foot to do this effectively. But you'll find one will be a little easier for you. If you do have an assistant, which is much better, I'm going to have the assistant do those motions. Can you lay on the other side? We'll show you better the hand position doing it this way as well, but I'm going to have the assistant, and you need to explain to the assistant a couple things. I'm going to explain that, first of all, you need full abduction here, and as you abduct, you can see the patient's naturally going to want to flex the hip. So I'm going to hold the hip here, but I want extension and abduction right here. Then I'm going to bring the hip into flexion, and I'm going to keep the tibia roughly parallel to the ground. The tendency is to go like this. So just bring the hip into flexion and adduction. When I get to this position, I'm going to put my hand on the foot, and I'm just going to put my hip against the knee. I'm going to push in a little bit, because if I just lower this and rotate it, the pelvis is going to roll over. So I'll hold it, and I'll actually push this way along the femur a little bit, and then adduct, and once I'm in that position, then I'll lower the foot to move the femur into external rotation. So all those have to be done in sequence. Now I'll take my contact. Once it's fully abducted, go ahead and raise it up higher. That's good right there. So I'll take my tension, being careful to be just off the bursa on the trochanter. So I'll take my tension right in here on one of those muscles, whichever I pick, hold that tension, and then they'll flex the hip, adduct a little bit more down towards the floor, and then hold it in, and then rotate. That's probably good enough right there. Hold it for a second right at the end. This is by far the best way to do it, because you get full shortening of the muscle and lengthening of the muscle, and that rotation really adds a lot to the end. But I'm in a real good position to hold this with both hands. The gluteus medius and minimus, very strong but very short muscles. They tend to really tighten up with people who do something that either does a repetitive motion or gets them shortened up and tight. They're very similar in motion to the hip rotators, but we're really going to have to do it in two parts, because the upper part, the fibers, are pretty much vertical, and part of it is in front of the point of rotation of the trochanter of the hip. So in doing the posterior part, it'll be just like a lot of the hip rotators. We'll start with the femur abducted, and I'm going to put my contact in this part, the bulk of the glute medius and minimus, and we'll treat them both together. And then the assistant will adduct, flex the hip and adduct, and then rotate. And as you rotate, this trochanter is going to be going this way. So you can see it's going to lengthen that gluteus medius and minimus. Once you've loosened those up completely, then we'll change our motion and do the front side. So lay on your other side. Thanks, Matt. To do the front side, I'm not going to use an assistant, because I need to feel what I'm doing, and I can do that better if I can control that. So grab just below the knee, make the patient just give you the weight of the leg, which is really hard to do, especially when you have your thumb on some spot that might be sore. But I'm going to flex, and I'm going to take a contact proximal on the front side of the glute medius and minimus, so it's right up in here towards the crest of the ilium. Superior, and then I'm going to extend the hip and adduct the hip, and it doesn't really matter what I do with the flexion extension of the knee, except that if I leave it a little flexed, the IT band and the TFL won't be as tight, and I can get through them easier. Once I'm here, I'm going to force that extension and adduction just a little bit while I maintain that proximal tension this way. Then I'm going to do the same thing, but reverse my tension, go right off the crest of the ilium, just in front of where the trochanter would be in the anatomical position. Take a distal tension, do the same motion, extend and adduct the femur, leave the knee bent just a little bit, and then move my hand above the knee so I can push it into extension and adduct pretty firmly as I exert a tension down here. When it's bad, you will find one band within those muscles and that's really tight and fibrous, and that's where you're going to have to concentrate your pressure. It's surprising how deep you have to go. The only way you're going to get really deep is to get this to really relax and fully abduct. It is only then that you can get in really deep past that greater trochanter without causing the muscle to spasm. And then very slowly bring this down, because they'll want to contract the muscle as you lower the leg. Stay deep, but just off the trochanter, and roll your thumb in deep if you have to. The short head of the biceps femoris is the only hamstring that doesn't cross the hip joint, so we don't have to worry about what the hip is doing. It's easiest to treat with the patient in the prone position, and you need to be careful or certain that you get full knee extension. The only way to do that is to move the foot off the side of the table so that it drops off the side, and you can see it will go farther than just resting it on the table. That will give you full extension of the knee. I'm going to start with the knee flexed, and then I'm going to find the tendons of the short and the long head of the biceps, and I'm going to go to the side of the long head, move in from the side, and take a proximal tension, then extend the knee fully all the way down beyond the table while I maintain a proximal tension. I will also need to go on the medial side of the long head of the biceps tendon, and then come lateral and then proximal into the short head of the biceps and take my tension this way. Now I can guide the foot and the lower leg with my other hand, or if I need to, I can have the patient hold right here, and I can use both hands to take a firm but deep pressure and then tension, and then have the patient extend the knee all of the way. The long head of the biceps femoris is a long muscle, involves two joints. The range of motion is quite long, so we're going to work it in a couple different ways. It's probably easiest to start with the patient prone, because that's where I have the best leverage. I can get in on the muscle when it's large, quite easily to do the bulk of the heavy work with the patient prone, and then have them lay on the side and do a motion that includes the hip motion, so you get more of a complete range of motion. So we'll start with patient prone, take my contact on the long head of the biceps, use both hands usually, and then take proximal tension, have the patient extend the knee. In order to get full extension of the knee, you may want to move the foot off the side of the table so that the foot can go down lower than the end of the table, and that will give you full extension of the knee. Now once that's done, lay on your right side. Once that's done, then I can start doing the work that gets more of the range of motion. So I can do it with one hand here and then guide with this. My thumb is on the long head of the biceps femoris, and I'll bring this into tension this way with a proximal tension, but you can see my thumb and wrist and hand and arm are all lined up, and I've got my elbow right in my hip. So I can go quite deep on this muscle, then shift to tension. And then what I want to do is move the leg pretty far, but I don't want to move it so far that I've got a tremendous amount of tension just from the stretch. If I need to work harder on the muscle, I'm going to lean on the muscle harder with my hand to get more tension, rather than move the leg really hard to get a stretch. And then I'll follow this all the way up. If I need to, I can just put the foot right in my hip here, and I can use both hands to get more strength to generate tension, and then just walk forward like this to get the motion. Once I get to the end here, I'm going to use my opposite hand, or the same hand here, back it up with this hand right against the ischial tuberosity, and then move my body forward to take the leg forward, keep the knee relatively straight, and get tension right on the attachment around the ischial tuberosity. When you find a spot on the ischial tuberosity that's really bad, what you're going to have to do is keep it relatively relaxed, compress and feel the ischial tuberosity, and on the long head of the biceps, it's going to be on the inferior lateral side of the ischial tuberosity. You should be able to find a real hard spot. If you do, compress on the distal side of that spot and then roll your thumb to stretch it proximally, but you'll still be right on the ischial tuberosity. Go very firmly on the contact, and then move the leg forward to stretch the muscle away from that attachment site. There are two major ways to work this semimembranosus tendinosus together, and you'll find one of those will be more mechanically advantageous to you. Both are similar in the fact that you want full range of motion as much as you can get, but you want to use depth of your contact and then tension and then pressure on the tension rather than a lot of pressure by just stretching the muscle by moving the leg. So to get the semimembranosus and tendinosus, I'll start with the leg in this position. If I can get a little knee flexion, that would be great, but it's still relatively short in this position. I'll take some depth, proximal tension, and then move the leg up and out this way. So I've got it flexed, a little bit abducted, but mostly flexed, and I can just lean right into the muscle here. Okay, lay on this side. This side. I can also work the semimembranosus and tendinosus from this position. I'll put my hand on the underside of the hamstrings here to get on those two muscles, take depth and then tension. Again, I've got my arm lined up with my hip, and I'll just move the leg forward and then lean in
onto the muscle as it goes forward. If I need to, I can use 2 hands, take my tension this way, and move the leg forward. Now again, when I get to the proximal end at the ischial tuberosity, for the semimembranosus and tendinosus, I'm going to be on the medial side of the ischial tuberosity most of the time, but feel around and find for the hard spot that's causing the problem. Take your tension proximally, but not off of the ischial tuberosity, and then move the leg forward. You're really going to have to lean into this and push pretty hard on that spot to break it down to where it's resilient again and more like a rubber band instead of a rope. The psoas and iliacus muscles can be worked in a similar fashion, just the hand contact's going to be in a different spot. Extremely important muscle for stability of the spine. You'll find that if it shortens up, someone's going to have problems with rising to a standing position after sitting for a while. They'll tend to have a facet syndrome and hyperlordosis, or the hip won't extend when they walk and run. There are some keys to working this muscle. We like to work it side-lying because then it's easy to get the intestines to move out of the way in the mesentery. You can use either hand, but what you want to avoid is going straight in with your fingers. If your fingers aren't extremely flexible, what tends to happen is they tend to get compressive and pointy when you go straight in. So you can go on the side of your hand this way or the side of your hand that way, whichever you find most comfortable. When you use the inferior hand, once you get everything set up, it's easier to apply your tension because this is lined up really well. The superior hand is actually easier to get in. So if you find that somebody's really sensitive and it's hard for them to let you get in, you might want to use your superior hand. The reason for that is if you go in sideways, your fingers tend to roll up like this and it feels like a nice soft contact as opposed to this being a hard contact. For this demonstration, I'll use the superior hand. And what I want to do is I want to get in behind the mesentery. But you don't have to jam yourself in really deep along the iliacus and then maintain that depth really hard as you go in. 2 things will happen if you do that. One is you'll be pulling the skin really far, and what you'll be feeling is a lot of skin tension. It'll take you a long time to get in, and by the time you get on the muscle, your fingers will be tired and they'll probably be hurting you. So be relatively light. I want to press in a little, but just enough to move the intestines out of the way. But you can see I'm not pressing in that hard. So I'll move in and move the intestine medial until I start going up on top of the intestine. Then I'm going to use this hand to hold them there, let go of this to let the skin tension go, and then start right where I left off, but now I don't have any skin tension, and move in a little farther. So 1, 2, or 3 times doing that, sliding in, alternating, holding it with this hand and sliding in with this hand, you can be in very quickly onto the psoas. Now, the mistake that's most commonly made is if you're working the psoas and not the iliacus, is usually you'll be too far lateral. So go in until you bump up against the psoas, and it's going to feel like you're almost past the midline, but in reality, you're going to be up against the spine, which is pretty far medial and pretty far posterior. Once I get on top of the psoas, then I'm going to press on it a little bit, and then turn my hand and exert a tension that feels like it's on a 30-degree angle. Because once the psoas starts to tighten up, it's going to push me laterally, and I've got to resist that so I stay on it and don't bounce off of it to the side. So I've got the psoas good and trapped. I'll push superior, hold a medial pressure, and then now I've got it good and trapped. And I'll have the patient straighten out the whole leg so it's down below, and then keep the knee straight and swing the leg behind as far as you can. Once you've done a few passes like this and you've gotten loosened up, then have the patient move the leg back and then extend the wrist and the elbow and reach back as far as you can and take a deep breath. On the last pass or 2, you want to do that to really get all that core fascia to let go around the psoas. When working the iliacus, you're going to use the same motions, but you're going to be much more inferior. So you're going to be down inside the pelvis on the anterior side of the ala and take your tension on the iliacus. So you won't be up here. You'll be down in there when you treat the iliacus, and then the leg goes back in the same way. Now, what I'm doing with my hip is I'm preventing the patient from rolling back like this. But if you block the pelvis too low, you'll find they can't extend the hip. So you may need to slide superior a little bit this so that the hip can extend. On the attachment of the psoas, you're going to have to work on exterior to the abdominal cavity and lay on your back. What I'm going to do is I'm going to start with the knee bent, and I'm going to feel just past the rectus femoris, just medial to that, and I'm going to take a very light pressure, just medial to the rectus femoris, but lateral to the femoral vein artery nerve, and I'm just going to hold my position there. And I'm going to grab the leg, and I'm kind of surround it up to the knee so the patient doesn't feel they need to lift the leg, and it contracts the muscle, and then it'll be sore. I'm holding my contact, not doing much tension, until I get the hip at least neutral, but maybe a little bit extended. Now I can start to take my pressure superior on the attachment of the psoas. And then I'm going to abduct and extend the hip, and then I'm going to push the lower leg to the lateral so that I'll internally rotate the femur a little bit. And then you'll feel the tension on the attachment of the psoas on the trochanter of the femur.